Shall we? Right. Good afternoon, everyone. Welcome to today's Implant Dentistry MSc Virtual Open Day. My name is Benjamin Williamson. I'm currently an implant dentistry student here at UCL, and your chair for this afternoon's together with Prina to my left-hand side here, who's also a current student on the implant dentistry program. We hope the session will address those course-specific questions you may have, and will help you to gain an insight into what it's really like to study on one of our master's programs. I'm delighted to welcome today's speaker, Dr. Dev Patel, who will provide you with a summary of our Implant Dentistry MSc program, and there will be a Q&A session for the second part of the event when you can ask questions to Dr. Patel, as well as myself and Prina. This session is being recorded and will be made available on our website following today's event. And with that, I'd like to introduce our speaker. We have Dr. Dev Patel. He's a dual specialist in prosthodontics and oral surgery, one of only a few in the UK. He is the director of the implant programs here at the Eastman Dental Institute here at University College London. So over to you, Dev.
Thank you very much, Ben. Very kind, and thank you, Prina, as well. So I'm going to split round, if I may, and start sharing my screen. So good afternoon now to everyone. Thank you for joining us today. Let's see if I can share my screen. Sharing this second. Sharing again. Okay. Okay, can everyone see my screen? Okay, perfect. So the plan really today is give an overview of implant dentistry. I know you guys are looking at potentially a master's in implants or getting training in implant dentistry. So I'm going to provide a little overview of implant dentistry and what's involved. Then look at training requirements. I mean, particularly if you're in the UK and GDC requirements for training, and then look at training opportunities and what you should be looking for and where. And then we'll have a Q&A at the end. And then luckily we have Prina and Ben here who will talk about their experiences on our program. So start with something really basic, which is, what is an implant? I mean, I don't want to teach you guys to suck eggs, but, fundamentally, the idea of having an implant is to replace a missing tooth. And that is often, but not always, the treatment of choice when we look at replacing teeth, when you particularly have good bone volume and low risk factors. And when we talk about an implant, it's really about the titanium screw that goes into the jawbone, which is then fused to the bone, which will then support a tooth replacement. And there's different ways of doing that, whether screw retained or cement retained. This is an old school cement retained restoration, which we do not are in favor of. We're very much in favor of screw retained restorations. So what's involved in regards to this? So, I mean, I'll kind of break it down to 5 key areas. So the first area really is patient selection, and that's really key for any restorative program. Selecting the right patient, working out whether it's a low-risk patient or high-risk patient is probably key. If you look at the patient we have in front of us here, this is an image I show a lot of our students, and she's basically presented with a root fracture on the upper left one, which needs to come out. However, she's also complaining about her front teeth and how she's unhappy with the color and she wants them whiter. I mean, they're all pretty white, as you can see. There's quite a lot of gingival recession. She's had these restorations only done relatively recently. I think it was about 3-4 years previously. And you see the gum recession. So she's got quite a thin biotype. This is a patient that's very challenging in terms of a case, because as soon as you remove this tooth, you're going to lose even more bone and soft tissue. And that means to reconstruct that bone and soft tissue to give you the perfect appearance is going to be very challenging. And with her expectation of having, perfect teeth I think we have to manage this patient in terms of realistic what we can or cannot achieve. We cannot achieve, perfection. And I'm very much against the word perfection because perfection is different in people's mindsets. But we do try to improve the appearance of what's there. And we can definitely provide a patient with a functional result, but can we provide it with an aesthetic result that actually is acceptable? And these are the challenges we have in terms of the world of implants, especially with the world that, the amount of money is spent on these things, the expectation becomes greater. They feel that the more money they spend, the higher their expectation. And I think as clinicians, we have to, manage that expectation from the outset and not, promise something that's beyond our means. So that really is key. And I think if you get this patient selection right, the rest becomes very straightforward. And then, choosing the patient, then moving on to planning, surgery, restoration, maintenance are really pretty straightforward stuff. And being on the program will give you a good foundation how you go through that whole process. So let's look at patient selection. I mean, patient selection involves, back to basics of undergrad, history examination, investigations. This is a patient who's got, multiple loose teeth due to a history of chronic periodontitis. You can see that plaque control is so poor that everything is failing. I mean, this patient can go to one of these all-on-4 type centers where they'll take all the teeth out, put some implants in, and give them a fixed bridge literally the same day. And it does work. However, if we don't address the cause of the problem, which is really a chronic adult periodontitis, and the fact that the patient doesn't clean their teeth, that means they won't clean their implants. And that means the risk of periimplantitis and bone loss around the implants is significantly greater, and they will end up with having failed implants as well. So we have to address the main issue. And realistically, a patient like this, we should really think about disease control and motivating the patient to clean their teeth and get them to actually experience the fact that they will have to potentially wear a removable denture. And a better option for the patient may be something like an implant over denture rather than a fixed bridge option. So these are things that we need to take into consideration rather than jump on the bandwagon of things like all-on-4 restorations, which I know is quite popular. The other thing we have to think about is, diagnosing and looking at the patient as a whole. So if you look at this DBT, you just see that patients got multiple crown restorations. They're all linked together. It's quite a lot of periodontal disease with bone loss, with apical infection on the bottom left-hand side. You can see the apical infection down to the apex of the bone. This is a failing dentition. And then suddenly the patient has seen what they call an implantologist who's done a sinus graft and blocked up the entire sinus and it's got a single implant. I mean, what benefit is this when everything else is failing? And so we really need to look at the whole picture in terms of patient selection and making sure that we are in the best interest of the patient at all times. And I always say to the patient, our objective is to keep what you have and then look at the things that you don't have, particularly learning teeth. So it really is quite critical. And, often we do jump the ship and forget the focus of the patient and the overall wellness of the patient. So that's really key. So, and diagnosis is key. I mean, if you've got failing dentition, which is related to periodontal disease, which is losing bone, that's going to have a big impact on your implant because that risk can transfer to the implants. So that is considered a risk and a significant risk factor. However, if you've lost a tooth because the patient knocked it from a trauma event, then that's potentially a low risk because if the bone levels are good, the patient maintenance is good, and it's a traumatic injury because they fallen over, or maybe from a failed root canal because of a caries issue, we don't get caries on teeth or on implants, but obviously on natural dentition you will. I mean, obviously there's elements of oral hygiene we need to take into consideration. So diagnosis is quite important to understand what has caused the failure so that we can see whether the implant will have a good success or not. So if you think about risk factors, some summary of little risk factors, the main ones that we always talk about is periodontal disease, smoking is a big risk factor, and bruxism. Bruxism is a big one because most people do clench and grind their teeth a lot. They're probably unaware of it. But the issue we have is with the implant, there is no periodontal ligament to provide any protection. A natural tooth has a PDL which acts as a shock absorber. So teeth can cope to a certain extent if they're abruxous, but an implant, there is no give. So all the forces will go on to either the restoration, the screw, the implant, or even the bone. So we have to keep that in mind. And as a result, things like patients wearing, looking at occlusal elements and making a hard splint and learning the importance of wearing a splint is really essential. Part of your prosthodontic training and implant training, and that's some key focus we have in our program. Other things you've got to think about is space analysis. I mean, how much space is there to actually replace an implant, and can we work within the biological means and the biological width of implants and teeth? And these are simple figures of distal space should be minimum 6 millimeters. Vertical space should be at least 5, so you have height for the restoration, and then you maintain biological width in terms of the implant. So these are some basic stuff that we look at. In terms of bone volume, ideally you want at least 8 to 10 millimeters of bone height. Bone height is more critical because you can build width, but height is much more harder to build. So as long as you're 8 to 10 millimeters high, you can predictably provide an implant restoration. Width becomes more challenging. If you have less than 6 millimeters, you will need to build the bone back up. And often when patients have thin buccal plates or labial plates, you will lose width. And I think we have also seen, and Ben and Prina have both seen situations where they've done cases, then they found out the width is not quite right, and they've had to rebuild the bone. And this is all part of the program that we offer. Planning wise, I mean, the key really for us is a screw retain restoration. Okay, so as part of the process of history examination, special tests, we need to also carry out, multi-study casts and look at the final restoration. So what we need to think about is with regards to implant is basically a support mechanism. So just like a tooth is a support mechanism, mucosa support, an implant is a support mechanism. So whether this tooth is supported by a denture, bridge, or implant, the replacement of that tooth is always going to be the same. So we have to always carry out what we've got a diagnosis to wax up and work out where is the final tooth position. And based on where that final tooth position, we can then look at plans of where the implant is. And if it's in a favorable position and there's adequate bone, that becomes a straightforward case. If there's an inadequate bone, then it becomes a more of a challenging case, and we have to look at the pros and cons of bone grafting or alternative options. But once we've done the planning, we do most of all our stuff is now digital. I say it's all digital planning. We make a surgical guide, which is also guided surgery, where we'll actually pre-plan exact position of the implant and then 3D print the position, and you use guided kits to place the implant exactly where we planned it. And that really is the mainstay of implant dentistry today. And that eliminates the risk of human error to a significant amount. And as the key to success really is to visualize the final result and then work backwards. And this is where digital implant planning has made a big impact in implant dentistry across the board. So let me just show you a quick video of one of our students from a few years back who presented the video for her exam. So I hope you can see this and hear this. So you can see she's got a fractured lower left 5, which was unrestorable. And so the tooth is removed like this, left to heal for a period of 3 months. This is CT scans across the section. As part of the process, we've go through the whole process of draping, preparation surgery, patient preparation. And this is quite new for people who've never done implants, because the style technique is quite critical, and it's important to get it all right. And you'll also need to get your team involved, your nurses and so forth, so they're familiar with it. So there's lots of discussion about whether you do a flat case or a flatless case. We always recommend a flat case because then you can see exactly what you've got. You can see we're using a pencil to work out exactly where we're placing implants. and then we rub that out. We use a surgical guide to place the implants, and this is the conventional route that we used to do. And we also recommend that you should know the conventional route of placing an implant as well as the fully guided options as well. In every stage, you have to check to make sure the position is correct. Because if you get the position correct, as you can see here, then the whole restoration is very straightforward and it becomes very easy. And now you can see the implant going in. And you've got good bone volume, you get a bit of good stability. The final check of the depth of the implant position, we know it needs to be at least 2 mils apical flange of the margin. A couple of screws placed. And a couple of interrupt sutures. So the surgical skill set you need to do implant surgery is actually not too bad. I mean, if you can remove the tooth surgically, then that's sufficient to be able to place implants. You don't need to be a max-back surgeon to do dental implants. And our belief is very much that whoever restores should place implants, particularly in straightforward cases. If it's difficult, challenging, then by all means you utilize the skills of a more experienced implant surgeon or an oral surgeon to help with grafting and stuff. As a restorative dentist, you should all be able to definitely restore implants and place straightforward ones. And that's really the objective of our program, is to teach dentists to be able to understand the basics of implants and then place and restore. And then you then develop your skill set further if surgery is of interest. If it's not, then you keep it simple and you work with the team. You can see here that these are very conventional techniques. This video was taken a few years ago where digital technology hadn't quite evolved. Nowadays, we don't really need to do this. We use scan bodies and to use intraoral scanners. And so the need for these impression techniques is less relevant, particularly for single restorations. But it's important to know the foundations of traditional techniques, so that if your digital techniques don't go quite hand to hand, then you have the backup, you have the understanding. So this is the wax up, the mock up. Always check the restoration on the working model. Always use shim stock to control occlusal schemes and contact points. It's quite critical for implants. And then once you're happy with all the restoration adjustments, that could then be took down. And contact points is one of the key things. You need to make sure there is a good contact, never an open contact, otherwise it becomes a food trap. And you don't want to have a too tight a contact, otherwise it becomes an orthodontic appliance and pushing the teeth. So getting the contact points, occlusal and proximal, are quite critical. And that's final restoration. So if I go back to my presentation, which is okay, so nowadays we've gone fully digital and fully guided. So this is a case where you can see the low left 5, which is why it's always a 5, but low left 5, you can see the 4's got a curved root to it. And because of that curved root, if you were to place the implant kind of blindly, your likelihood of affecting the vitality of this adjacent tooth is quite high, and that can result in devitalization. And that has happened in the past. So you have to be quite careful of the position of the implant three-dimensionally. So this is where digital planning is quite critical, and getting that done 3D on a software package is paramount. And that's what we do here. And then once you've planned it, you can 3D print a surgical guide, and that's what this is on the right, a surgical guide with a special guided kit to get the placement of the implant exactly where we want. And then you can see the students followed exactly what's planned, and it's perfectly planned and placed according to the planning. So you can't really get it wrong. And lower 5, you've got the mental frame, and the low down here, which the risk is quite high. So, controlling that and controlling all the factors to get the best outcome is in terms of what guided surgery is all about, because that reduces the risk. If you think about other cases, this is a case I did just after COVID. The patient's got 2 laterals missing. Now, if you see my planning, this is the tooth on the left-hand side, and you can see that my placement is actually slightly more lingual or more palatal, because I want screw access with a single fossa. If I were to just place the implant where the bone was, that would be my line and where the bone is. However, my screw access will be for the inside of the ledge, and that's not going to be very favorable for screw retain restoration. And we really want screw retain restorations because these restorations will need maintenance like everything else in the mouth. So you will need to be able to unscrew it at some point, clean it all up, screw it back on, etc. So for us to have screw access is critical. So that means placement is quite critical. So again, on the right side, you can see that if you look at what the bone is, if I were to place where the bone is, I'll be within inside the ledge. They will not give me screw access. That will be a cement restoration, which we want to try and avoid. So our planning is slightly a subtle difference between there and there. Now, if you try to do that freehand, it's quite difficult to assess the 2 positions realistically, clinically. So using guided surgery will give you much more control in trying to get exactly where you want. And this is the surgical guide. And then clinically, I hope we've got the end of these days, but it was quite traumatic after this. I think it's my first implant case, and we had to be all fully gowned, and COVID days, rubber dam for implant placement. That was a bit crazy, wasn't that? That was my first and last, I think. So, but it's quite fun to take some pictures. But it was a case that we managed to do, and these are 2 missing lateral, and then the end result was very straightforward, very easy. So this is the kind of stuff that you should all be able to do on a day-to-day basis where you've got good bone volume. So how do I start? So identify suitable patients for implant treatment. That's your first line. I'm sure you have patients in your practices who have missing teeth or even have had implants. I'm familiar with it. I would also suggest, at least start observing patients who need treatment. So if you don't have, if you must have patients you refer. So if you have in-house implant surgeons, that's the best thing. Go and see them do all the planning and the placement and the restorations, so you get an understanding of what's involved. That really is useful. And if it's your patient, there's absolutely no reason why you can't observe their treatment. So also that will be a start point, and then you can then think about learning. And if you want to develop your skill sets, really, you have to decide whether you want to just look at restoring implants alone. And if you do want to just restore, not do any surgery, not get involved with blood, then you can just do simple restorations. And we've created this PG certificate in implant dentistry, which is a 1-year program. And it's our first year of our 3-year MSc program. So that will be a start point. And often people say, I'm not sure implants is for me. So I've created this program, and I've revamped my program about 3 times over the last 12 years, because just to address people's concerns and issues regards to implant training, because it is quite long and expensive. So the PG certificate is a good startup to see if it's of interest, and at least at the end of it, you'll be able to restore implants and plan cases, which this day and age, you all should be able to do. If you're interested to go further forwards and do more surgery, then I'll suggest to move forward to the diploma in implant dentistry, which is the 2-year program. This way you'll be able to train to place and restore implants. So both Ben and Prina are on the 2nd-year program where they're actually placing implants and do the surgical aspects of it now. And that'll give you a much more stronger confidence in being able to do the surgical aspects as well as restoring. The MSc is the 3rd-year program, which is basically a research project. The main difference between diploma and the MSc is just purely a research project. There's no additional clinical input. So those who are interested in an academic side of things, they can progress to MSc if they wish to. And the final thing I'd say is you must know how to maintain implants. If you don't get involved with implants in any way, I'm sure you will see patients who have implants, and you need to have the confidence to say, okay, well, I know how to maintain this. I know what's healthy, what's not healthy, what should be referred, what shouldn't be referred. Even patients who need implants and you don't want to do it, you should be able to give patient an idea. Okay, well, this looks very straightforward. You should think about an implant, or this looks complex. So understanding implants today is quite critical. It's a shame that as an undergrad in the UK, the training is not great, but I mean, there's a lot to cover. So implant dentistry is pretty much a postgraduate training program, just like orthodontics is a postgrad, just the same as sedation is a postgrad. So for you to be involved in these things, you have to do postgrad training. So what are the requirements? So if you think about requirements, GDC have a policy statement which goes into some depth. It's based by a group of people who looked at the training standards, and it's published by the Faculty of GDPs, which is no longer in existence. Now it's just General College of General
Council of General Dentistry.
That's the one, yeah. So there's a new one. But they have the document. But if you go to GDC, we'll link you to the exact details that they prefer. And that really is the basis by which we do all our training. The training standard really divides into two aspects. So replacement of missing dentition involving straightforward cases, and then replacement of missing dentition involving complex cases. So what that basically means is that for most dentists, your training should be involved with the straightforward cases, and then for the specialists will be the complex. It's the same as endo. So for example, endodontics, every dentist can do endo in practice. But anything more complicated, you send to a specialist. And implant dentistry is kind of set up in a similar fashion. The only thing is that you will need to do a training program that meets either one or two. I think one basically involves some form of structured training, either a certificate or diploma, and number two will involve some sort of specialist training. It's all down to interpretation. So this is our interpretation of it. So if you're going to do straightforward cases, before undertaking implant treatment, a dentist must develop competence in procedures involved in the clinical assessment, planning, placing, and restoration of implants. This involves a whole series of things from start to finish. It's not something that you can go on a weekend program and bang a whole lot of implants and say, yeah, I'm an expert in implants. There's a whole process, and it should be done through a training program. They don't specify how long that training program is, but I would say a minimum of a year is quite critical for us to be able to have a better understanding of it. What type of training and where? I mean, there's lots of training courses out there, lots of short CPD courses. So, for straightforward level stuff, if you want to have an understanding, there are lots of courses which involves some basic implant restorative courses, implant overdentures. We do quite a few short courses. We used to do a lot pre-COVID, and we're looking to bring those back in the near future. If you're already experienced in implants, then you can think about more advanced courses like bone grafting, sinus grafting, all of 4 courses, so that you can develop your skill set. We usually recommend our implant students who've done the diploma or MSc to think about the advanced courses once they get familiar with everything we've taught them in practice. In terms of formal accredited university programs, I mean, that's what our mainstay of our training is. So the PG Certificate in Implant Dentistry really is our new program, which has been in existence for the last couple of years. So I think you guys are year 2 of it, I think, or second cohort, I think, yeah. Mm-hmm. So that's a good way to start, and that is our mainstay. Once you progress from that, you can then go to diploma, which is basically the surgical side, and the 3rd year is the masters. All the information is on our website. A quick summary of these things. In terms of the MSc, it's a 3-year blended part-time program. So when you say blended part-time means usually 1 day a week or 2 days a month. So our year 1 program is 2 days a month. Diploma is 1 day a week, and the MSc is like 1 day a month. So it gives you an idea of timescales of commitment. So you can still be in practice and still work and earn and study at the same time. The only thing I would suggest that, if you're going to embark on some training program with implants, make sure you are in an environment where you can put that into practice. Because if you're in an environment where you can't, then it's kind of wasted and you will de-skill very quickly. So trying to get yourself in an environment where you can, put into practice what we teach you. All our teaching faculty are specialists in their field. So, you are taught by specialists. So you have an opportunity to actually tap into, their knowledge and skill set. So it's not the world of just implants. Not big fan of implant specialists per se. Most of our dentists are prosthodontists, specialist prosthodontists, where you have the option to look at a case overall and the best option for restoring that case. And it's not always as simple as just restoring that single tooth. It's all look in the whole mouth, look at the occlusion, look at the wear, and look at the overall picture in terms of function. So it's important to work with a group of specialists who have a full understanding of the patient's needs. We do have some invited speakers who come and join our program, and they vary from year to year. And the final thing is that we do have this recognition of prior learning. So if you've already been on a program, so a lot of people say to me, Dev, oh, I've already done this program. Can I get some credits? I have devised a program where there is an opportunity to have recognition of prior learning, but it is subject for approval. So if that's something you've done, you need to write in and explain what you've done, and we can then consider it. But I would say you need to have done at least a 5 to 10 day program for us to even consider it. But the recognition will give you credits for our PG certificate only is the first year, but we still want you to do the whole year 1 program, because we want to make sure that your foundation knowledge is the same as everyone else. But you may get some credits in terms of module credits and even fee credits as well. The program covers lots of things: assessment, occlusion, planning. We have to do a lot of photography and videography, which is also useful for self-learning as well. We'll look at the science of implant dentistry. And then on the clinical side of things, implant aesthetics, guided surgery, conventional surgery is also important. We touch on immediate implants, and then also grafting hard and soft tissue. And then we have to then think about implant prosthetics, occlusion, maintenance, complications, and the whole thing has to be evidence-based as well. It's quite a comprehensive process that we spread out over 2 to 3 years. All of our teaching is hands-on didactic teaching. We are quite prescriptive in what we want you to do. It's not like go and read a book and learn about it. It's very much we will teach you, we'll show you, and we want to see you do it as well. All the treatment, particularly the year 2 program, where you start seeing patients, is under our direct supervision. You'll be put into tutor groups so that you have a tutor to which you will plan and treat your patients. With any university program, it has to be an assessment. So there's assessment end of each year. We try to keep it simple as possible, because I know you're busy GDP dentists working in practice, so you don't want to spend hours writing 3-hour essays. So we don't do any of those. It's really a simple practical exam, MSA, which is multiple short answer questions or multiple choice questions. So it's relatively straightforward. You will have a viva to discuss how you plan a case. And then at the end of the year 2 program, you have to present 1 comprehensive case. Over the years, it was 8 cases, then became 4 cases, and now it's just 1. Because if you can do 1, then it really doesn't matter, because it shows that you are able to do what you've been taught. So these are the PG certificate program. It's a 1-year blended program, up to 30 contact days. We have 4 2 to 3 day blocks of teaching, usually October, December, February, April. This is useful for people who are working and studying, living abroad. So the idea of PG certificate is really for a global audience, and then they can then fly in if need be 3-4 times a year for a bit of block teaching. The rest is done blended learning online. A good way to start learning about implants. It's not too onerous in terms of taking time out of practice, and ideally suited for people who are abroad. Anyone in the UK will have the opportunity to actually be on site, because it's hybrid teaching, but it's also done remotely for those who are unable to. And that's done as a result of feedback from the students. It used to be all remote, but now we do it hybrid. Cost of the training is different between home and overseas, so depending on how you recognize the fee structure, but I'm sure the admission department will be able to advise on that. PG diploma, so that's the 2nd year. So after you've done the PG certificate, you have an option to then progress to the diploma if you want to. If you don't want to, then you can exit and then get a PG certificate, and then you can start restoring implants and you're good to go. If you want to develop your skill set and start placing implants, then you move on to the second year, which is diploma. It's quite intensive, as you might ask the guys here. It's a 1-year program, 1 day a month as a minimum. It's a lot of contact days. But the idea here is that you will actually treat patients. So you'll bring your patients to us. We will plan the case with you. We'll do the CT scans here on site, and then you'll then actually select the right patients and help you to see 2 patients to place and restore during that year. It's quite tight in terms of timing, so we tend to start in the summer to start assessing, and then we can then at least get the implants placed in the autumn early on. Who should apply now? Because it involves patient treatment, really it's only limited to people within the UK who are GDC registered, because you have to bring a patient to us. Unfortunately, we're unable to provide patients, so you would have to bring patients to us. We usually recommend you try and identify 4 patients so that you have 2 to do here and 2 in your own practice. So ideally, what you want to do is get those 2 done with us. And then as soon as they're done, you should try and get the other 2 done in your practice soon after, so that you can then maintain the momentum. The hardest bit is actually transferring your clinical skills into your practice. So the sooner you start doing that, the better it is. Cost year 1's PG cert is 11.3, and then year 2 is 6 weeks more because of the number of days and stuff. And the final thing is the masters. Masters really it's a research project. And if your interest is academia and you want to get a paper and do a bit of research, then this is a good option. The only thing is that there is a continuation requirement. You will need to get a distinction as an average over your first 2 years to be able to progress to diploma. So to the MSc, to be able to do the MSc program. So these kind of the options that are available to you. Is a step-by-step process. So you're not committing to all of it in one hit, and you can exit at any point. So it's very flexible. So in terms of application process, if you are non-UK dentist, so you're from overseas, then you should apply for the postgraduate certificate, because once you apply for that, you cannot progress any further. And there's a whole process within UCL that stops you from progressing. If you're UK based with GDC registration and you want to consider placing implants, then you should apply for the postgrad in the MSc program. And by applying for the MSc program, it doesn't commit you to it to the full year, 3 years. What it does is puts you on the path towards it, and then at any point you can exit. That's the key aspect of it. What we're looking for, ideally you want someone with at least a year's postgraduate experience. The more experience you have, the better it is. The more broader your experience, the better it is as well. You don't need to have any implant experience at all, because we'll teach you from zero knowledge. What will be useful is some restorative general experience. Being in practice is helpful. Some oral surgery experience is also very helpful. I mean, if you're able to raise a flap and suture, that will set you up very nicely to be able to do implants. If you had done any oral surgery previously, then even better. The general thing I would suggest is that, if you can take out a straightforward case, tooth extraction wise, and raise a flap and then close with sutures, you can do straightforward implant cases. If you can take an impacted wisdom tooth out, which means raising a flap, sectioning a tooth, removing bone, and then closing the sutures, then you could do most bone grafting cases. Okay, so they're the 2 surgical skill sets you need to have if you want to look at surgical. And if you don't have it, then that's what you want to try and get under your belt before you embark on the implant program. Otherwise, you'll spend probably, and I've seen this, we book 3 hours to place your first implant, and I will say probably the first 2 hours is spent either raising a flap or closing. It's not about the placement implant at all, and that's because of experience. So if you develop your skill sets in those, that will help you out really well. We want key motivated people to learn, and also you need to have time to study. If you're in the middle of getting married or moving house or buying a practice or etc., you may struggle. So you want to make sure you do it in a window where you have time to study, so you can make the maximum amount of time with us, so your learning is to the highest level. We do provide a bit of support, so we have industry come and support. So Noble Biocare as our key sponsor for our program at the moment. So, and they will do kindly donate some implants to you guys and sponsor dinners and prizes, etc. And Gaishik is another company that we work with who provide biomaterials and offer access to their lectures. And obviously, as a UCL student, there's full resource of students. You are considered a full-time student, not full-time student, but a fully registered student. So you have access to all their facilities in terms of online training, electronic libraries, ebooks. So it's a very powerful resource. And, you know, when I say online training, you could actually learn how to make a website if you want, because it's got nothing to do with dentistry or implants, but the resources for the whole UCL, so for every student. So a lot of opportunity if you have other interests. And final thing is relocation. I mean, if you are, for those who have been around for a long time, our institute used to be on Grazing Road at Eastman Dental Hospital, and that's where all our training used to be. We've now moved to the med school at the Rockefeller building, which is on Gower Street, which is really nice because we're right in the heart of all the UCL campus. And so you will have access to, and all your teaching will be done within the UCL premises in and around Gower Street. But mostly is in the Rockefeller building, which is part of the med school. Okay, thank you so much for everyone for listening. This is, if you want to follow us, this is UCL Implants. This is our Instagram page. So do follow us. We'll post our activities every so often. That's my email address if you have any queries. This is the scan code for our website for more details. I'm going to stop sharing now and then pass this over to Ben and Pina.
Yes, a lot of information there, very informative, thank you. We will now start the Q&A. Please add any questions to the Q&A box and we will do our best to try and address them.
So I've got the first question here from Hammond. Are we able to get a copy of the main slides from the slideshow?
Yes, you can, yes. In fact, this is recorded, so and I think what we'll do is maybe we can get it posted onto the website so you can actually look at it anytime.
Okay,
yeah,
that's great. And then a second question, can a GDC registered overseas GDP be considered as UK based or overseas in terms of fees?
You'd have to speak to the admissions department on the practicality or technicality of that, because that is I'm not sure the ins and outs of the technicality of what's considered as home student and overseas student. But if you're GDC registered and you're practicing in the UK, then you can definitely look at joining the Year 2 program. But in terms of fees, you need to check with fees and admissions on that.
Those are currently the only 2 questions that we've had. So any more questions? Any questions for Ben or me as current students as well? Let's use the chat box. Okay, so perhaps Ben, you could sort of talk about what you think the most useful aspect of the couple of years has been.
For me, not only did I sort of start this course having very, very limited experience of implants, I restored a couple of very simple cases. For me, it's actually had an impact on my general dentistry as well. I mean, it's been a while since my undergraduate BDS studying. As Deb was saying, obviously occlusion is very, very important in terms of implant planning, implant maintenance and that sort of stuff. And some of the more sort of in-depth knowledge we've learned about occlusion that obviously wasn't covered at undergraduate level has actually had a knock-on effect on not just my implant dentistry, but in general dentistry and, you know, sort of conventional crown and bridge work and denture making, implants sort of aside. So it's generally just taken my general dentistry up a level as well.
I would really echo that because prior to starting this course, I'd only had a year of general practice after my foundation year. I spent 3 years doing MaxFax, so I didn't have a lot of restorative experience, but I think the other thing is there's a mixture of different experience levels within our year. So it's really nice to learn from people who've been doing implants, for example, for quite a long time, and some of us are really inexperienced. So that's been great. We've got a couple more questions now. So what's your experience as a UCL student, and what made you select UCL over the others? Well, I chose Eastman because it's a world-renowned institution. You've got the best specialists here. So I chose it for the rigorous academia and the reputation. I must say, because I'm busy at GDP and lots of other things going on in life, I don't actually get involved in student life as much as I perhaps could or should. But there is that opportunity if you want to. There's always getting emails about clubs and meetings that are going on campus, so you can really take advantage of that if you want to.
I'm very similar actually, Prina. Although I don't live in London, I did my undergraduate studying in London, and just always had an affinity for the city, and the opportunity to come back fairly frequently was quite attractive. And as you said, obviously the Eastman's kind of like a world-renowned name, and it was a fairly safe bet, and just what I think the flexibility of the program as well was what attracted to me. So if I started on the PG certificate and decided that it wasn't for me, I had the option of leaving after year one and still having a qualification. It wasn't a complete loss. And just the same as you, Prina, I'm sort of working 4, 5, 6 days a week, depending on my schedule. I don't really get involved too much as a UCL student in terms of sort of extracurricular activities on campus, but there is plenty of opportunity to do so if you wish.
So we have another question that's asking, what's all the documentation required for admission?
I think when you apply, it will give you a list of things. So I think usually it's you have to do a CV, you have to have references, and they're the two main things. And it's the two references that tends to be the thing that slows the whole process down. I think the admissions is open. The deadline for applications is June, so you've got plenty of time. But what I would say is that the sooner you apply, the better it is, because we usually kind of do it in little sections, so we don't have a whole lot at the end. But what we want to always try to do is select a whole group of students who are a mix. Like what Prina said, that we do have some people who are quite experienced and people not so experienced, because what it does, that dynamic allows us to mix and match the teaching, because the experienced guys want to take it to another higher level, whereas the inexperienced want to keep it quite low in basics. And often these people who are highly experienced forget the basics. So we'll bring them down and then bring these up. So we'll balance out. So it works well.
It works very well. There is also a personal statement that we had to write, which it's not long, but it's just about why you want to embark on the course and what experience you've got thus far. And the last question I've got here, I'm not fond of oral surgeries. Am I okay as a candidate for the implant course? So
yes, absolutely. I mean, so if you think about in practice, I said the implant is just a support mechanism. So it's a treatment option to replace a missing tooth. So as a restorative dentist, which most general dentists are, your option is denture bridge implant. Okay, so implants are an option. In restorative dentistry, you need to understand how to provide an implant for a patient. Now, providing implants is two aspects. One is a surgical aspect, one is a prosthodontic aspect. So our 1 certificate program covers the restorative elements. And that will allow you to at least assess patients and then restore implants. And you don't have to do any surgery at all, because then you work with another surgeon who does the implant for you. Either they have someone in-house in their practice, or someone's visiting, or you refer out to a center. And then you work as a team. So yeah, very much so. And I think as every dentist in the UK, well, every dentist across the world should be able to restore dental implants. And that should be part of the undergrad curriculum. And I think in the fullness of time, we'll probably have that. But I think at the moment, everyone has to train themselves into it. So you don't need to be able to do surgery. Surgery is only for those who has interest. And that's why it's split into year 1 and year 2. Hope that helps.
Any more questions? I think that's seems to be all that
Yeah.
there is.
Everyone's happy to wrap it up. Have you got any closing statements there?
So no, so I would say that, you know, it's good to research. I mean, obviously I'm a bit biased about our program and how good it is, and that's why we've got our students here who give a better insight on their experience of these things. But you know, the best way to actually know what's good is actually speak to the students, maybe more candidly, maybe not because you're part of the program director, it might be a bit, but you know, if you speak to them more candidly about these things and contact them, that really is the best way to get feedback direct from students. But do your research. Is quite an expensive process, and you know that investment is quite critical. But I would highly recommend everyone to be involved in implants somewhere along the line, and you need to have some foundation training. So you know you should definitely look at embarking on that. And good luck. If you have any question or queries, please don't hesitate to contact me. We'll be running this session again. I think we've got 2 more sessions. I think one in April, one in May. So watch out on the websites. There's also an FAQ document that should be on the website somewhere, which will load up, which will give you a lot more information as well if you need it. Yeah. Good luck, everyone. Thanks for listening.
Thank you guys, and thank you, Deb.
Thanks. Thanks, guys.